Good afternoon, everyone. My name is Tang Fengyuan, and I'm from School of Public Health, Zhejiang University, China. There are many concerns about body size change and disease risk. It has been the subject of many debates recently, and I'm grateful for the chance to talk about the associations of child to adult body size change with risk of hypertension and severe non-alcoholic fatty liver disease. I have divided my talk into the following main areas. First is research background, methods, results, discussion, and conclusions. The first is the research background. Let's start with some general information on child obesity. Child obesity is a significant public health concern. According to the data from Lancet Research, from 1990 to 2022, the global rate of obesity among children increased fourfold. This means that 159 million children and adolescents worldwide are currently suffering from obesity. Obesity during childhood can affect long-term body size changes, and overweight children are more likely to become obese adults. The child to adult body size change is independently linked to hypertension and non-alcoholic fatty liver disease, namely NAFLD, in adulthood. However, there are still some research gaps. Firstly, it's unsure that whether childhood underweight contributes to a higher risk of hypertension in adulthood. And we don't know which body size change type is associated with the greatest risk of adulthood hypertension. Thirdly, it's unsure whether normal adult body size can negate the detrimental effects of childhood obesity. Fourthly, limited study explored the association of body size change and NAFLD. Fifthly, previous studies often used small participant numbers and many of previous studies linked sufficient follow-up, particularly among older age groups. So, by using the data from UK Biobank, a large population-based cohort study, the objective of this research is to investigate whether child to adult body size changes are associated with hypertension and severe NAFLD in adulthood. Okay, the second is the research methods. More than 500,000 individuals completed the baseline survey and remained during follow-up. We excluded participants based on several criteria. We excluded those with self-reported or diagnosed pre-existing hypertension. We also excluded those diagnosed with other liver disease, and we excluded pregnant women. And last, we excluded severe NAFLD participants who experienced events within the first 2 years of follow-up to mitigate reverse causality effects. So finally, the final participant count stood at 222,420. The categorization of childhood obesity size was derived from responses to a questionnaire. Participants were asked, when you were 10 years old, compared to the average, would you describe yourself as thinner, about average, or plumper? With the answer of thinner representing a low child body size, average representing average child body size, and plumper representing high child body size. When it comes to adulthood body size categories, the WHO's criteria for defining overweight and obesity were initially applied to categorize the participants. However, only 0.6% of the total population was identified as low adult body size. To address this issue, adult body size groups was established by matching the corresponding proportion of child body size growth. So, subsequently, 9 child to body size categories were formulated by amalgamating child and adult body size groups, namely child low, adult average, child low, adult high, and so on. The incident hypertension was defined as hospitalization or death due to hypertension using the ICD-10 codes I10 to I15. Similarly, severe NAFLD referred to hospitalization or death due to NAFLD or non-alcoholic steatohepatitis, which was represented by ICD-10 codes K760 and K758. When it comes to covariates, we considered covariates such as age, sex, ethnicity, educational attainment, and the Townsend deprivation index. We also accounted for lifestyle factors such as diet, drinking status, smoking status, physical activity time, and sedentary time. The Kaplan-Meier estimator was used to assess the relationship between the 9 child to adult body size categories with the incidence of hypertension and severe NAFLD. The Cox proportional hazard regression was used to quantify the association and calculate the hazard ratios and 95% confidence intervals, with the child average, adult average category serving as a reference. When it comes to sensitivity analysis, a sensitivity analysis was conducted using the broader NAFLD definition, and a sensitivity analysis was conducted by controlling for family history of hypertension and metabolic risk factors. Thirdly, a sensitive analysis was conducted to assess the potential impact of birth weight on the primary results. Fourthly, stratification by sex and age groups was performed to examine the influence of body size changes from childhood to middle-aged or adult or older adulthood. Finally, we included prevalent cases using logistic regression. The third is the research results. The number and proportions of the 9 body size categories are presented in this table. We can find that child average, adult average made up the largest proportion, and child high, adult low accounted for the least. During a median follow-up period of about 13 years for hypertension and NAFLD, 28,662 individuals were diagnosed with hypertension and or severe NAFLD. The incidence rates were 10.07 per 1,000 person years for hypertension and 0.59 for severe NAFLD. The Kaplan-Meier estimator demonstrated that all individuals with a high adult body size had the highest cumulative incidence of hypertension, namely the top 3 lines, and those with low adult body size had the lowest cumulative incidence of hypertension, namely the bottom three lines. We found similar results in severe NAFLD. After controlling for socioeconomic and lifestyle factors, among 9 child to adult body size categories, all individuals with a high adult body size were at a high risk of developing hypertension, and those with low adult body size were associated with the lowest risk of hypertension compared to the individuals who kept an average body size. In detail, individuals having low child body size and high adult body size had the highest incidence, with the HR for hypertension was 2.01. For individuals with high child body size, those having average body size in adulthood had a similar risk compared to those having persistent average body size. We also found similar results in severe NAFLD. These associations were observed independently of confounding variables across all subgroups examined and remained consistent in nearly all sensitivity analyses. The last part is discussion and conclusions. The findings indicated that low child body size was linked to an elevated risk of hypertension and severe NAFLD within each adult body size group. Individuals with low body size during childhood and high body size in adulthood exhibited the highest disease risk. Additionally, individuals who had high child body size but normal adult body size had the risks of the two diseases that were similar to those of persons who had an average body size consistently. Those with high body size and low adult body size had the lower disease risk. Virus metabolic and pathophysiological mechanisms may explain the results. First is the obesity-related metabolic dysfunction. The second is excessive weight gain. The third is adipose tissue. And the fourth is sympathetic nervous system activity. This study used long-term follow-up data from a large cohort, adjusting for a large range of potential confounders and selecting objective and accurate disease endpoints. However, this study is not exempt from limitations. Firstly, the child body size was determined by recall, which may be subject to bias. Secondly, this study linked access to data on childhood socioeconomic status, which may be associated with diseases such as obesity and hypertension in adulthood. Thirdly, incident hypertension and NAFLD were defined based on registers, which may lead to the omission of individuals who are not documented in the medical or death registries. Finally, this study was limited to the United Kingdom, so generalizability to other regions and ethnicities needs to be further verified. Our findings demonstrate that childliness exacerbates the risk of both hypertension and severe NAFLD, with individuals who had low child body size and high adult body size exhibiting the highest disease risk. Adults who overcome child obesity in adulthood can negate the detrimental effects of child obesity. This underscores the importance of not only promoting weight loss in obese children, but also reinforcing weight management in lean children. That's all for my presentation, and welcome feedback and criticism. Thank you.